Assalamu alaikum wa rahmatullahi wa barakatuhu. Guys, welcome back to the channel of First and Medical Notes. So today we will discuss interpreting arterial blood gases as a separate topic, because this is very important. That's why I have modified the previous video and decided to discuss this topic separately. So we will discuss very conceptually this topic, so that in the context of respiratory failure, we'll discuss ABG. Okay, so first of all, when we perform arterial blood gas analysis, the steps are: first you confirm whether there is hypoxemia or not. So when there is hypoxemia, the PaO₂ will be less than 8 kilopascals, nothing but less than 80 mmHg. Okay, or in the pulse oximetry it will be SaO₂ less than 94. On room air it will be less than 94. So that confirms that there is type 1 respiratory failure, type 1 hypoxic respiratory failure. Next, you will move on to evaluate for PaCO₂. So now if PaCO₂ is more than 45 mmHg, then it is type 2 respiratory failure. Okay, now one thing is like this: PaO₂ is less than 80 mmHg plus PaCO₂ is more than 45, that is type 2, and PaO₂ is less than 80 and PaCO₂ is normal, that is less than 45, and this is type 1 respiratory failure. Okay, this plus. Okay, so this is type 1 respiratory failure, this is type 2 respiratory failure. Now you have known the type of respiratory failure: type 1 meaning hypoxemic or hypercapnic. Okay, now again you will dive deep to know the causes of these respiratory failures. So after this, you will calculate something known as capital A minus small a PaO₂ gradient. This is nothing but capital A is the amount of oxygen contained in the alveoli, and small a is the amount of oxygen contained in the pulmonary arteries. Okay, so the difference between these two is known as A minus A2 gradient. The difference between these two is A minus A2 gradient. Now based on this is a very important thing, okay, to differentiate between to dive into the causes. So normally this A minus A2 gradient is approximately equal or less than 26 mmHg, as this is given here. Okay, like this is from Oxford. Okay, this is from Oxford textbook. Now you should calculate capital PaO₂, that's alveolar oxygen, by the formula like this, fraction of inspired oxygen. So this is actually on room air, this is a 0.21. okay, and if you connect cannula, you add 4. I will discuss that one. Okay, and into 760, this is atmospheric pressure, and this is pressure of oxygen in the lungs, that is minus 47. 760 minus 47, then PaCO₂, which you will take it from the ABG analysis. Then R is respiratory quotient, and usually I am saying usually it is approximately 0.8. And if somebody is taking high carbohydrate diet, then it will be approximately 1. The value of R will be 1. Okay, usually it will be 0.8. If someone is taking high carbohydrate diet, then it will be approximately 1. If someone is taking high lipid diet, then it will be 0.7. okay, so just remember that R is normally 0.8. okay, an average value. So whenever you take this formula, just put R as 0.8 and calculate PaO₂. Minusing this small PaO₂ from the large, you will get the gradient 26 mmHg. Normally the gradient, the difference between alveolar oxygen and arterial oxygen is normally less than or equal to 26 mmHg. Okay, now Okay, that is the thing. Now moving on to the next steps. Now if the gradient is high, meaning if it is more than 26 mmHg, if it is more than 26 mmHg, the gradient is high, then that suggests type 1 respiratory failure. Type 1 respiratory failure. If the gradient is high, then that suggests type 1 respiratory failure. And meaning the problem is with gas exchange in the lungs. The problem is with gas exchange within the lungs. The problem is not alveolar hypoventilation. The problem is not alveolar hypoventilation. The problem is with the gas exchange within the lungs. Meaning alveoli is having good oxygen, but due to some reason oxygen content of the artery is less, so the gradient is high. Okay, so when this will decrease, the value of this will be increased. Okay, that means the gas exchange is impaired. Okay, either due to VQ mismatch or due to shunt. Okay, or due to shunt or due to fibrosis. These three are the main causes, which we have dealt in the mechanism of hypoxemic respiratory failure, type 1 respiratory failure. Okay, so these three causes will be there. So when the A minus A2 gradient is high, that means the problem is with pulmonary gas exchange. Okay, and if the gradient is normal or low, meaning less than or equal to 26 mmHg, then that means the gas exchange is normal. The gradient is normal. The gas exchange is normal. That's why the gradient is maintained. Or low. Low meaning A is decreasing, but A2 is normal. So the value will become low. Okay, A is decreasing. The alveolar oxygen is decreasing. So why alveolar oxygen is decreasing? Oxygen is not coming. Alveolar ventilation is impaired. That is nothing but oxygen is not coming. Okay, oxygen is not coming. So that's why either the oxygen is okay. So if it is normal or it is low, that means oxygen is not the problem is not with gas exchange in the lungs. The problem is with ventilation. And that the causes can be can't breathe and won't breathe. So now you have calculated. First you will calculate PaO₂, then PCO2, then A minus A2. This will give you clue. The next clue you will get from 100% oxygen therapy. 100% by giving 100% oxygen to the patient. Okay, so when 100% oxygen corrects the hypoxemia, then that in type 1 respiratory failure, when A minus A2 is increased and 100% oxygen corrects the hypoxemia, then that means the problem is with VQ mismatch. Problem is within lungs. Okay, mismatch means some alveoli are ventilated but not perfused properly, and some are perfused properly but not ventilated properly. That is VQ mismatch. And if with 100% oxygen also that is not correcting, then that means whole of the blood is shunted. Maximum lungs are impaired. Maximum portion of the normal lungs is impaired. The problem is more severe. Even after giving 100% oxygen, the lungs, the saturation is not increasing. That means the problem is severe and more of the lungs is affected. That you can see in intrapulmonary shunt and cardiac shunts. We will discuss later. So this is how you step by step calculate, analyze ABG. So FiO2 fraction of inspired oxygen depends upon the method or delivery device which you are using. So simple, if you are first thing which you use and which is very much compliant to the patient is nasal cannula. So 1 liter per minute will have 24% of FiO2 or 0.24. Okay, increasing in each increase of 1 liter will increase the inspired oxygen by 4%. So this will become 28% at 2 liters, and at 3 liters this will become 32%. At 4 liters this will become 36%, 5 40%, 6 44%, and up to 6 this will apply like this. Above 6 this maths will not apply, and this is only for nasal cannula, not for other devices. Okay, so that this simple maths you remember. There is something other formula also you can use, but this is the simple way by which you can calculate FiO2 on patients on nasal cannula. Okay, on simple face mask, which can deliver up to 5 to 6 liters per minute, you can get approximately 40 to 60% of FiO2, meaning 0.4 to 0.6 FiO2. Okay, and in non-rebreather mask, at flow rate of 10 to 15 liter per minute, approximately 60 to 90% or more than 90% you can get FiO2, or you can remove 0.6 to 0.9 or more than 0.9 also if you go than more than 10 to 15 liters. Okay, now if you are using HFNC, high flow nasal cannula, then up to 60 liter per minute you can give flow rate, and the saturation fraction of FiO2 can be 1. That means 100% oxygen you can give. So that's this HFNC will help us to differentiate between the causes, because it can give 100% oxygen. No. Now moving forwards, this is the workup. Understanding the workup is important. Now this is acute hypoxemia, meaning acute type 1 respiratory failure. So you have confirmed with pulse oximetry that there is saturation is less than 40%. Now you will calculate ABG. Okay, along with ABG you will calculate A minus A gradient. If the A minus A gradient is normal, then that means the pulmonary gas exchange is normal, but their problem is with oxygen is not getting in. Oxygen is not getting in into the lungs, but the pulmonary gas exchange is normal. That means alveolar hypoventilation. The problem is with alveolar hypoventilation. So in that case, you will have increased PaCO₂. Okay, and hypoventilation causes can be due to sedation, or in cases of severe COPD, where you will have diffuse lung involvement. Okay, obstructive sleep apnea, obese patients, diaphragmatic paralysis, neuromuscular disorders. So these are the causes. We will discuss later on how to differentiate this. Now, if this is normal, normally when there is alveolar hypoventilation, there will be increased PaCO₂. But when you find normal PaCO₂, then you will have some problem, and fraction of inspired oxygen is also decreased, or PiO₂ is also decreased. That means the oxygen tank is either empty, or in the atmosphere only you are not having oxygen. This is important. In the atmosphere only you are not having oxygen, or the tank from which you are giving the oxygen, that is empty. So the atmosphere is not having oxygen. That's why alveolar hypoventilation is there. Okay, that is the cause of alveolar. That's okay. PaCO₂ is normal. Actually, when there is alveolar hypoventilation, along with the decreased intake of oxygen, there will be retaining of carbon dioxide. So this is something unusual which is happening. So we should think of some other thing. What is that other thing? That is nothing but empty oxygen tank or high altitude patients. Okay. So whenever there is alveolar hypoventilation, there is decreased oxygen, but retaining of carbon dioxide is usually that is there. Okay. Now, when there is increased A minus A2 gradient, that means the pulmonary gas exchange is affected. Either the alveoli ventilation is affected, or the perfusion is affected. Okay. Okay, now this has grades. I will explain this one. When you administer 100% of oxygen, what this means, you are flooding the lungs. You are flooding the lungs with oxygen, loading the lungs with oxygen. Okay, so when there is a partial in type 1 respiratory failure, there is partial a portion minimum. I mean, comparatively, the affected portion of the lung will be less, and the normal portion of the lungs will be more. So in that cases, there will be VQ mismatch. No, so the other portions will pump out oxygen. Okay, that you will see in VQ mismatch. So correction of that region means still the affected portion of the lung is less, and non-affected is more. That's why more that means. So VQ mismatch. Remember, after administration of oxygen, if the hypoxemia corrects, then the cause is VQ mismatch, and if it doesn't correct, then the cause is shunt. Shunt means bypassing, total bypass of blood. Okay, so the causes can be either airway causes like asthma and COPD, or alveolar causes like pulmonary edema in early stages of pulmonary edema and congestive heart failure. Remember this, in early stages. Okay, early stages it will correct with 100% oxygen. Early stages of pulmonary edema and congestive heart failure, it will start from basis and reach to the apex. And in case of pulmonary embolism, not massive. Okay, not massive. In massive pulmonarism, it will be total shunt. Okay, so massive, it will in pulmonary embolism. So these are the 3 causes of VQ mismatch, and that will correct with oxygen. Okay, that is a good thing. There is a problem that is partial, but when there is no correction with 100% oxygen, that means there is complete blockade. That's why the blood is bypassing from the lungs. Complete blockade, and the blood is bypassing from the lungs. That is known as shunt. So what is happening here is there will be 2 types of some shunts: intrapulmonary shunts and cardiac shunts. Intrapulmonary shunts, what happens is the alveoli the pulmonary edema or some filling due to fluid or due to blood or due to congestion, a maximum portion of the alveoli of the lungs are loaded with fluid. So or maximum portion of the lung alveoli are collapsed or have undergone atelectasis. That's why oxygen giving oxygen is you are giving 100% oxygen, that is not getting corrected, and the blood vessels are normal and they are getting bypassed. That means if I speak in simple words, maximum portion of the lungs is affected and minimum portion is normal. Now maximum portion of the lung is affected and minimum portion is normal. That's why there is intrapulmonary shunting. Here there is partial problem. Here there is maximum portion of the lung is affected. So the causes are alveolar collapse, atelectasis, alveolar filling due to pulmonary edema in severe cases, okay, or ARDS also you can take, and cardiac shunting causes like right to left shunt, cardiac shunt, or pulmonary AV malformations. This is the chart. Okay, this is explaining about hypoxemic respiratory failure. Now if you are having hypoxemia only with exertion, then the problem is fibrosis. So this is also the cause of type 1 respiratory failure. Then that is the cause is interstitial lung disease. Moving forwards, now coming to type, one more thing I forgot to say in this type 1 respiratory failure is that acute respiratory failure can be acute, okay, one, or it can be acute on chronic. In acute respiratory failure, in hypercapnic respiratory failure, I should say, okay, hypercapnic respiratory failure can be, I will discuss it here only. Hypercapnic respiratory failure, type 2 respiratory failure, either it can be acute or either it can be acute and chronic. In acute hypercapnic respiratory failure, okay, the pH will change, pH of the lung blood will change, but there will be no increase in bicarbonate increase will not be there in acute hypercapnic respiratory failure, because kidneys are not getting time to correct that acidosis. So there will be uncompensated respiratory acidosis will be there in cases of acute hypercapnic respiratory failure. Bicarbonate will be normal, pH will be decreased. In cases of acute on chronic respiratory failure, pH will go down and bicarbonate will be more. This is the difference between acute and chronic hypercapnic respiratory failure. That's what I want to say. So measuring bicarbonate is also important. That will be there in ABG. So causes of, so if there is increased PaCO₂, then the cause is alveolar hypoventilation. Now the causes of alveolar hypoventilation can be divided as won't breathe and can't breathe. Won't breathe is nothing but the centers are not sending signals. So the main respiratory center is affected and that is not sending signals through the respiratory system is normal, chest wall is normal, everything is normal, but the respiratory centers are not sending signals to the respiratory center. That's why there is hypoventilation. Okay, so what are the what you will see? You will see a decreased respiratory drive. A decreased respiratory drive will suggest won't breathe. Okay, that means center respiratory center is affected. So patient will try to take voluntarily hyperventilation. There will be voluntary hyperventilation. Patient will take voluntary breaths. Okay, because we have some control over our respiration. So so that's why patient will take voluntary breaths, and there will be normal maximum inspiratory pressure and A minus A gradient. Normal A minus A gradient meaning the pulmonary gas exchange is normal, lung unit is normal. Okay, and normal inspiratory pressure, that means the chest wall, muscles, and the neuromuscular pathways, everything is normal. These things these imply. So what can be the causes? Causes can be, number one is metabolic alkalosis. So metabolic alkalosis will affect the respiratory system and that will cause respiratory failure. Primary neurologic causes and secondary neurologic causes. Primary can be a stroke or a tumor, okay, or primary alveolar hypoventilation, some problem with respiratory center that is causing primary alveolar hypoventilation. Most common, remember this one, stroke and tumor. Secondary neurologic cause, some other agents affecting the respiratory system. So that can be sedatives, okay, sedatives, or some CNS infection, CNS encephalitis, meningitis, okay, and hypothyroidism, mixed edema, coma. myxedema coma. So that is affecting the respiratory system. That's why there is decreased respiratory drive. That's why there is respiratory failure. So these three are the causes of decreased respiratory drive. Now coming to the can't breathe causes. Can't breathe causes, again, what I said is these are the same. So 100% oxygen, that is not correcting the acute hypoxemic respiratory failure. What in the next stage, what will happen in that, I will show you. Okay, so it is like this. Okay, this is the first stage. If it is not corrected, then this will move on to this stage, and sorry, this is the second stage. In case not excluding this cardiac causes, okay, don't exclude, only pulmonary. This will move on to the second case, and then this will move on to this third case. That is how an acute hypoxemic respiratory failure, or chronic also, this will happen in minutes, in hours, that will happen in days to months. Okay, hypoxemic respiratory failure will progress like this. Okay, here also you will have maximum amount of lung is affected, very minimum amount of lung is normal. Okay, that's why there is increased PaO₂ CO2. So the patient is not able to breathe even though he has the capacity to breathe, but because of increased respiratory load. So remember the causes of can't breathe. The causes are increased respiratory load. This is increased respiratory load. Why there is increased respiratory load? Because maximum amount of normal lung is affected and minimum amount is normal. So the causes can so what happens in that case, the dead space will increase. VD is nothing but dead space, and tidal volume also will decrease. So if there is increased dead space and there is decreased tidal volume, the causes are either airways or lung parenchyma. There will be abnormal PFTs, decreased end tidal carbon dioxide. Okay, so airways include asthma, COPD, obstructive sleep apnea, cystic fibrosis, and bronchiectasis. In these two, what happens is the secretions will block the airways. Okay, lung parenchyma, so it can be severe emphysema. Okay, chronic interstitial lung disease, acute meaning initial phases of fibrosis, it will have hypoxic. When it progresses to, I said no, second stage, that will pass to the third stage. So as time progresses, it will have increased PaCO₂. And CHF and pulmonary edema, when these are severe, then they will have increased PaCO₂. Okay, so either the causes are if the dead space are increased and tidal volume is decreased, then these are the causes. Lungs and airways are the causes. Now only if the tidal volume is decreased, that means there is some problem with the neural pathways or neuromuscular pathway or muscle pathway or the mechanics of the respiratory system. Meaning the problem with some chest wall, spinal wall, some problem with that. Okay, so when there is decreased tidal volume, the causes can be neuromuscular system, or the problem can be chest wall or pleural causes. In neuromuscular system, there will be decreased maximum inspiratory capacity and decreased maximum expiratory capacity, because nerves are affected, muscles are affected. Okay, so they will not help the lungs to exhale or inhale. So the causes are neuromuscular causes. So neuropathies like cervical spine disease, spinal cause, phrenic nerve palsy, Guillain-Barré syndrome, aortic lateral sclerosis, or junctional causes like myasthenia gravis, myopathies like due to decreased phosphate or muscular dystrophies. Okay, so these are the causes when there is decreased tidal volume. Along with decreased tidal volume, you will have decreased maximum inspiratory capacity and maximum expiratory capacity. The muscles are also affected and the nerves are affected. In chest wall and pleural causes, there will be decreased compliance. Here there will be decreased compliance of lungs. Actually, lungs compliance will be decreased. Can't breathe is nothing but increased respiratory load. Increased respiratory load can be due to decreased lung compliance or decreased chest wall and pleural compliance, or due to some disease of neuromuscular system. So abnormal maximum expiratory pressure or abnormal CT scan will show the problem. So chest wall problems like obesity, kyphosis, lateral bending or forward bending of spine, or pleural causes can be fibrosis and effusion. So that is how you break down this ABG. Okay, so this is due to, can't breathe is nothing but due to increased respiratory load. Pathologically, I am explaining you. expiratory load. Decreased expiratory load can be due to decreased lung compliance, okay, decreased lung compliance, or decreased compliance of chest wall or pleura, okay. In that you will have all this abnormal pulmonary function test, or it can be due to neuromuscular causes that cause increased respiratory load, or it can be won't breathe. Won't breathe nothing but respiratory center is affected here. Respiratory center is affected, okay. Pulmonary gas exchange will be normal, that's why A1 will be normal, and normal lungs will have maximum inspiratory capacity and maximum expiratory capacity. So metabolic causes, primary neurologic causes, and secondary neurologic causes, okay. Thank you for your listening. This is the detailed explanation of ABG in the context of respiratory failure. If any improvement is required, please comment in the comment box, okay. Thank you.